You just clocked into your night shift and you have been floated to the MICU. There's another COVID spike, which I'm not by any means manifesting. I do not want to bring that upon us. But in this scenario, half of the unit is COVID patients. You have a sick patient. They're on day 6. They have COVID. They are prone, which means they have a poor P to F ratio of note. They have borderline kidney function. They are on a fentanyl, propofol, Nimbex, and norepinephrine drip. When you're tracing your lines, you notice that the patient is on 0.1 mics per kg of levo, 25 mics per kg of propofol, 7 milligrams of Nimbex, and their blood pressure is 130/58 with a heart rate of 128. They're breathing with the ventilator. Their oxygen saturation is 88, and their end-tidal CO2 is 40. What do we have happening here? Welcome to this episode where today we're talking about neuromuscular relaxing agents, neuromuscular blocking agents, and or paralytic drips is another name that you've probably heard on the unit. This episode, we're talking about paralytic drips, what you need to know as an ICU nurse, monitoring, how to monitor, everything that you want to know and more. As a quick intro, my name is Anna. I am now a second year RRNA, meaning I am 2 out of 3 years into CRNA school. I was a travel nurse in the COVID ICUs for about 2 years, and I was a CVICU nurse before that. And this is my business partner.
I'm Chrissy. I'm a nurse anesthetist. I've been a CRNA for 6 years now. Before that, I was a CVICU nurse, and together we host this Confident Care Academy podcast and membership where we teach in-depth pathophysiology and pharmacology to critical care nurses and future CRNAs, much like yourself if you're listening. And in this podcast, we give out free information. And recently, we've had a lot of questions about train of 4 monitoring. We are rolling out a lecture on paralysis. Wonderful colleague, friend, and partner, Kate. We thought we'd come on here and talk about this today for you guys. This is a huge topic in critical care, and I think it's often poorly understood because paralyzing agents are used when we first intubate patients, but we're not often managing it actively, or at least not often enough to truly understand it at the depth that nurses really need to safely take care of these patients. So we're really excited to get into this today. So without further ado, let's dive into the first topic, which is the biggest fear that I think everyone has, being awake and paralyzed. I can't think of anything scarier, Anna. Can you?
No, that it genuinely nightmare fuel to be paralyzed and aware. And this is why we are so passionate about educating nurses. We believe in y'all. And I think that nurses are really smart and very capable of learning everything. And there's not a ton of information that's out there. And the reason that this topic matters a lot is that you're taking care of patients who might be on a paralytic drip, and you might need to advocate that they get adequate sedation and pain control on board. So speaking of awake and paralyzed, Chrissy, what's going on in this scenario that we opened up the episode with?
So the scenario that we opened up the episode, of course, there are going to be a lot other outside factors and clues that go into this. But if you notice Anna's breakdown, I'm just going to pull it up right here. So this patient is on a norepinephrine infusion. What is that? 0.1 mics per kilo per minute of norepi. And a pretty low dose of propofol. I know it's kind of hard for you guys to know what a high or low dose of a propofol infusion is, but 25 mics per kilo per minute of propofol is at the lower end. This is like a light sedation range. And for a patient who's prone, meaning belly down, and paralyzed, who, I don't see any mention of any alternative pain control options on board. I didn't see you mention a fentanyl infusion or anything like that. If they're fully paralyzed and prone, this patient could be awake and paralyzed. Their blood pressure is pretty high and their heart rate's pretty high considering how sick they are. 130/58, a heart rate of 128. They're fighting the ventilator potentially. Well, actually, no, they can't fight the ventilator because they're paralyzed. But either way, a patient who is paralyzed and sedated, who's tachycardic and with a high blood pressure, higher than you would expect for that low of a dose of norepinephrine, could potentially be having pain and or awareness. So, some things to keep in mind before we, dive into like, how do you know? How do you understand? I think that one of the biggest misconceptions is that like, if the patient looks comfortable on a cisatracurium or Nimbex infusion, I've definitely heard people say like, oh, well, they look comfortable, so we can turn down the sedation. Like I've heard people say this in real life. We've had CCA members tell us about this happening on their units. And of course, the patient looks comfortable. They can't move. They're paralyzed. And that has nothing to do with their pain control levels or whether their brain is awake or not. So we're going to dive into how to parse all of these out in this episode. So remember, we also have an episode that I want to point you guys to. We'll link it below. Pain control and sedation are also not the same thing. That's another really important to drive home. Sleepiness doesn't mean you're out of pain. Like, yes, you can ultimately sedate someone to the point where they're not aware of pain. And yes, pain medications often have sedating effects. Like they might make you sleepy, but it doesn't mean they're the same thing. And oftentimes your patients need both, and they work synergistically. So if you have a little bit of sedation and a little bit of pain control, you're going to have a much better level of patient comfort with fewer side effects because you'll be able to have fewer doses of both medications, but a much better overall control of pain and sedation because they work together synergistically. But we have a full episode on that linked below as well.
And shameless plug for all of the ICU nurses out there and all the people who are interested in CRNA school. Check out the membership because that's where we have in-depth lectures about propofol, epinephrine, vasopressin. And at the end of the day, you need to know how these medications truly work. And it's sadly not as common as it should be that everybody really understands exactly how all of our medications work. I'm thinking about the propofol lecture right now. I think y'all should definitely check it out. Link in the description for the free epinephrine mini lecture. So definitely check that out as you're diving into it. As we're getting into these different medications, these different paralytics, which is the next point, I want to just quickly add that as a nurse, I didn't understand why paralytics were sometimes called paralytics and why they were sometimes called neuromuscular blocking agents or neuromuscular relaxants. I didn't understand the difference between that. Do you want to I feel like that segues into our next point, Chrissy. Do you want to explain like why that is, why they're sometimes called different things interchangeably?
This is it's so funny because the most confusing point is that a lot of times colloquially in anesthesia, we'll call them muscle relaxants with an ANTS. Because it relaxes the muscle, right? And we'll talk about, and we're gonna quiz Anna on this. We're gonna have Anna describe to us how these drugs work because she is studying this in school, so it's gonna be a good time for her to shine. We're really excited about that. But that's why it's called a muscle relaxant. And I think the general population, we often, when we hear the word muscle relax, we think of muscle relaxers, which is a totally different class of drugs, right? Drugs that reduce spasms in muscles. So, oh my gosh, I'm trying to think of an example, like baclofen. We think of baclofen when we think muscle relaxer, right? But a muscle relaxant is a paralytic, a paralyzing agent, one that causes paralysis or blocks. So a neuromuscular blockade, it blocks acetylcholine at the neuromuscular junction. So Anna, I'm going to use this opportunity to sort of ask you what you understand about how do neuromuscular blockers work in the first place. And we'll kind of like dive into that a little bit so people get a better understanding of what we're talking about. All
right, Chrissy, jump in here and add your knowledge and correct me. But my current understanding as as someone who is actively learning this is that the paralytics work at the site where we're stopping muscle contraction. So what do we need to do in order to stop a muscle contraction? You go all the way back to an action potential, which is that electrical stimulation from the central nervous system that travels down the nerve as electricity, and that's the action potential. And then where that nerve is going to connect with the muscle is the space between the nerve and the muscle is what we call neuromuscular junction / synaptic cleft. And the synaptic cleft is where our paralytics work. And we have two different types of paralytics. We have one type of paralytic that's called a depolarizing neuromuscular blocker, which would be Suxin Choline, that has the action potential, which is that electrical impulse travel all the way down to that neuromuscular junction. And then it passes through that synaptic cleft in the form of acetylcholine and then causes the muscles to contract. And that would be Suxin Choline.
Right. So the action potential itself, I just want to add this in to clarify for the kids. So the electricity itself is not, we talk about like the nervous system in the body. This is going back to nursing school. When signals travel through the nervous system, it goes from an electrical to a chemical transition. So when it's traveling through the axon, through the nerve tissue itself, it's an action potential that jumps from nerve cell to nerve cell to nerve cell. And you guys might remember like the receiving end is typically a dendrite. It's got like all the little spiky receivers. And then you have the axon sheath that's myelinated. You could think of that as like the insulation, and that allows the action potential to travel very quickly down the nerve. And then we have the synaptic cleft, which is the end point of the nerve that releases some sort of a chemical in little packets called vesicles. So the action potential, the end point is that it's going to cause the end of the nerve cell to release the contents of the vesicles to dump the chemicals into the synaptic cleft. So it's a cleft, it's a gap between two cells. And that chemical can travel across the cleft, that space, that gap, to the next cell. So in the nervous system, it would normally go to like the next dendrite. But in this case, the nerve is interfacing with the muscle. So the muscle is going to receive acetylcholine, and that's going to trigger a series of events that's going to end in muscle contraction normally. So, nerve, action potential, chemical signal, acetylcholine, and then once that binds, that's when it sets off the next change of events. So back to depolarizing muscle agents.
It's really good stuff. And I feel like everybody should definitely go check out the Train of 4 lecture in the Confident Care Academy membership. We're going to have a slide up on screen here where this is one of the images that one of our amazing guest lecturers, Kate, who's a pediatric CRNA, she drew this picture here of the neuromuscular junction in which all of the different electrolytes and the vesicles and the acetylcholine. Definitely go check out that lecture. It was great. It actually inspired us to write this episode. So definitely check it out. And then also just listen to it a couple of different times. This is something that's going to take repetition. But then I'm just echoing what Chrissy said, that you've got the depolarizing neuromuscular blocker, which would be the Suxin Choline is the one that we use both in anesthesia and sometimes in the ICU. And that one takes the action potential, and then that action potential is translated to acetylcholine. Acetylcholine crosses that synaptic cleft. It then causes the muscles to contract, and then it stays bound to the little channels, and then it doesn't allow any more action potentials to go through. So then the muscles are contracted and can no longer receive further electrical stimulus, and the patient will be paralyzed at that point. And that's one type of neuromuscular blocker. That would be the depolarizing neuromuscular blocker, Suxin Choline. As you can imagine, there's some other things with that. And yes, Chrissy, what were you saying?
No, I was just going to say, so it's the Suxin Choline itself. And Anna knows this. I'm just like clarifying so you guys understand. The medication itself is what's binding to that receptor site. It is shaped very similar to acetylcholine, which is why it can still bind that site and initially trigger that muscle contraction. And we'll talk about what that means in a second. But then it stops any further acetylcholine from binding it because it's now like sitting on that site and chilling there. It's the Suxin Choline itself that is binding the site and sitting there and preventing any further muscle contractions, because acetylcholine cannot bind for those 5 minutes, just to kind of drive that point home.
As a learner, I took a stab at depolarizing neuromuscular blockers. Do you want to explain a non-depolarizing neuromuscular blocker? And then if I have anything to add, I'll add it.
Yeah. So Okay. So non-depolarizing is like the ones that we see a lot more in the ICU because there's so many contraindications or reasons not to use succinylcholine, especially in a critically ill population. But you do still see it sometimes. And we'll talk about things for you to know as a nurse, especially a nurse who's in an ICU and sees a lot of rapid sequence intubations, I'm sure. But the non-depolarizing neuromuscular blockers, that's all of the other ones other than succinylcholine, they are going to compete for that site as well, but they don't send off they don't trigger a muscle contraction. So they bind to that site, that postsynaptic nicotinic receptor. So we have different types of receptors in the body that bind to acetylcholine. We have nicotinic receptors, muscarinic receptors. Nicotinic receptors are the ones that are at the neuromuscular junction and cause muscle contraction. So the non-depolarizers, the rocuronium, the vecuronium, the cisatracurium, those are the ones that are going to sit there, bind that site, and prevent acetylcholine from binding. They have a much longer duration of action. Much more than 5 minutes. They have a much longer duration of action. A full induction dose is usually like 30 to 45 minutes in duration before we start to see it wear off. And this is what's really important for the ICU nurse to know. If we do an induction RSI dose, especially of a drug like rocuronium, and then we've given an induction agent with it like etomidate or propofol, those medications, etomidate and propofol, last about 5 minutes. Your rocuronium lasts about 45 minutes. We have 40 minutes now where the patient could potentially be awake and paralyzed. So this is where it's important to have something on board that's going to keep your patient asleep. So make sure you have a propofol infusion and or a fentanyl infusion ready to go to keep your patient asleep and comfortable after the RSI is taking place. And ask for those orders before we even get there, because once you call anesthesia stat, lots of people come to help. Delegate that to another nurse. Ask them to get a propofol infusion ready and ask a provider for an order for it ahead of time. That way we don't have these gaps in time.
So there's so much here, even about how these medications are broken down and metabolized, what parts of the body metabolize and break these medications down, why you might choose one over the other, all of which I think honestly is a bit too much for this podcast episode. I think that it's really helpful to understand that depolarizing medications like succinylcholine, how those work, and then you have your non-depolarizing neuromuscular blockers, which are more commonly used in the ICU. Your Nimbex, your ROC, these are the things you're going to use most often. And then I think circling it back to why this matters in the ICU side of things, the pain control, the sedation, the amnesia that we want for our patients to have. We don't want for them to be awake and paralyzed. I think these are takeaways that would have really helped me a lot. And then also what these medications could do and what like the negative side effects could be would have really helped me as an ICU nurse, which I feel like leads into the next thing, which is just what do you need to know? What are some other big takeaways? We talked about, hey, if you use ROC for a rapid sequence intubation, patient's going to be, paralyzed for 30, 45 minutes and they need pain control and sedation on board. Okay, well, that's a big thing to know. What are some other big things to know, right? Let's talk about succinylcholine, right, Chrissy?
Oh, there's so many things to think about with succinylcholine. It's because of that mechanism of action, and this is why we spoke about it. When we have that depolarization of like basically all of your muscle groups at the same time, and this really would take a whole nother lecture just to talk about the action potential and like potassium release, but there is a transient increase in potassium in the bloodstream because of when the muscle contracts, potassium is released, essentially, in short. And imagine all of your muscles contracting at the same time because we've given this medication that contracts them all at the same time. You might see something called fasciculations. So the patient might they might twitch or clench up. They can also get masseter muscle rigidity, so like tension in the muscle in the jaw. And they get that potassium increase, among many other things, increases in intracranial pressure transiently, intragastric pressure transiently, any type of pressure increase you can think of. But if your patient already has a high potassium level and they have chronic kidney disease, especially a very severe case of chronic kidney disease, they're not able to like rapidly, I guess clear is the best kind of way I can put it, their potassium, we are in trouble. We could have a life-threatening hyperkalemic event. So a lot of times when the provider comes to the unit to intubate, we're going to ask you, what's the patient's ejection fraction? What is their potassium level? And you're gonna be like, why do they need to know the potassium level? Because we're worried. We want to know if we can give succinylcholine or not. We might ask what their creatinine is also. We want to know their kidney function.
And why do they ask ejection fraction?
Ooh, such a good question. We're going to ask about, and honestly, I always just look this up myself, but we're going to ask about heart function and ejection fraction in general, because that's going to help us know what type of sedative we can put the patient off to sleep with. I think for a long time in critical care, most people just gave etomidate and succinylcholine or rocuronium, but etomidate, even a one-time dose, can cause pretty significant adrenocortical suppression, which basically we need to have that system intact, your adrenal glands, in order to mount an appropriate stress response. We want your adrenal glands to be able to produce enough cortisol for you to have an appropriate stress response to critical illness. And even a one-time dose can impair that, which, now we're starting to get away from using etomidate for everyone, because even though it's quote unquote cardiac stable, let's be honest, large doses of etomidate can still cause some hypotension and negative effects, but it causes less myocardial depression than propofol would. Sometimes it is appropriate to just give some propofol in the ICU. You can give a decreased dose and do it safely. You can give it along with a little bit of a vasopressor to kind of counteract its hypotensive effects. Or you could choose another agent altogether. Maybe you use ketamine or something else. But understanding the patient's heart function lets us kind of make that decision about what's best for the patient in that moment, instead of blindly giving everyone this drug, etomidate, that has harmful effects in and of itself. But important things for you to know as the ICU nurse: if a patient is receiving succinylcholine, don't be scared if they're moving. It doesn't mean they're awake. That is just a normal response. It's just muscle twitching, like as the drug is setting up and starting to work. Know what the potassium and kidney function is, and be ready to tell those numbers to the provider. So it's the creatinine with the potassium. Know that the paralysis only lasts for about 5 minutes, which is great. And then there is a chance of it triggering something called malignant hyperthermia as well, which, it's not super common. It's pretty rare, but malignant hyperthermia is a life-threatening reaction to this medication, as well as some other anesthetics. It's a genetic condition that is inherited. And I'm trying to think of the best way to summarize this quickly. Essentially, the muscle cell, there's a defect in the ryanodine receptor, which is responsible for sequestering calcium back into the calcium stores, the sarcoplasmic reticulum of the muscle cell. There's something wrong with it. So essentially it keeps pumping out calcium, and the patient's body goes into a hypermetabolic state. So lots of potassium release, lots of breakdown of the muscle cells. They can go into renal failure. Their body temperature goes up very quickly. That's why it's called malignant hyperthermia. It's a life-threatening state. And we do have drugs in the hospital ready to treat it, but it might not be readily available in the ICU. So all of these things are important to know if the patient gets succinylcholine.
Yeah. So succinylcholine is, with all of these negative side effects, I would find myself as an ICU nurse wondering, oh, well, why would you even give Sux at all? Why would you choose succinylcholine at all for a rapid sequence intubation if all of these things could be side effects? And at the end of the day, I will say, Chrissy, correct me if you're wrong, or if I'm wrong, I didn't see Sux given for a lot of RSIs. It was almost always rock. However, one of the perks is that it lasts about 5 to 10 minutes. So then for a patient who needs for intubation, but not necessarily long-term mechanical ventilation, sedation, and pain control, it's nice that it's not going to last the patient won't be paralyzed for an hour. That is one thing to know. But then, just like Chrissy said, if you're the ICU nurse, I would always know the patient's creatinine, their potassium, and their ejection fraction. That'll be things that the provider is going to ask if they're coming in for an intubation. And if you want to know more about all this, definitely check out the Train of 4 monitoring lecture, which kind of leads into really the next point, right? So how are you monitoring patients if they are receiving doses continually or for longer acting neuromuscular blocking agents? How do you monitor if a paralytic has worn off or not? What are the ways that we can kind of do that in the ICU, then also in the OR?
Well, let's talk about a few things here. So, there is one scenario in which you might see Suxin Choline given in the ICU, and that is because sometimes if a patient is anticipated to be a difficult intubation, traditionally, before, I trained in the days before Sugammadex was available, right? So we'll talk about a little bit of reversal of these drugs in this episode. But these drugs, the non-depolarizers, rocuronium and so on, and vecuronium, they can be reversed with different types of reversal agents. And if you're giving an RSI dose of rocuronium specifically, so rocuronium is the one non-depolarizer that we use for rapid sequence intubation. You give it in a larger dose than your typical intubating dose, and it takes about 60 seconds for it to have peak effect, and then you're able to intubate. If you give a very large dose, like we said, lasts for 45 minutes, what happens if you can't intubate or ventilate that patient? Well, now you're screwed, right?
That's scary.
You got to do a surgical airway. That's it. That's your next option. You can't just wake the patient up. You've committed to paralysis. So in situations where you saw people with sketchy airways, our only option for a while was Suxin Choline or an awake intubation or no paralyzing agent. And that can be a really challenging place to be depending on how the patient presents and what's going on. Now that Sugammadex exists, you can give a 16 milligram per kilogram dose to reverse the rocuronium, which is a lot, but it's not in stock in every hospital because it's very expensive and it's not always readily available on the units. So you could still see some Suxin Choline floating around for very specific circumstances. And that is why that does happen sometimes. Before we had Sugammadex, our other options for reversal agents, you couldn't reverse a large RSI dose until the rock had already worn off. And that was not that long ago. And again, Sugammadex is very expensive, so it's not an option in every hospital on every unit. They might have to go down to the OR and get it. That might be too much time. So that's just kind of answering that question. But as far as how do you tell if a patient is awake and paralyzed? How do we monitor that? How do we understand sedation versus paralysis levels? That's where we get into Bis monitoring and just understanding signs of lightness in general. So in the operating room, we don't always have brain monitors on patients that tell us about depth of anesthesia. We do have Bis monitors available and SED lines, which is similar to Bis, but gives you a little bit more information. These are stickers you place across the patient's forehead. You may or may not have seen it on your unit, depending on how much money and resources your hospital has. And it essentially looks at the EEG waves of the patient. And with an algorithm, spits out a number that gives you an idea of how deep their anesthetic level is, if they're asleep or awake or not. And different numbers correlate to different things. And when you get really good at it, you can look at the different patterns and know the difference between artifact and it's kind of like a look back in time. It's not necessarily a live reading. It's a calculation of the average of your brain waves over the last few minutes, but you can look at the screen and look at the brain waves. And when you really study it, you can kind of tell even before the number catches up, what's going on with your patient. More importantly is understanding that the patient's body will tell you if they're awake or not, unless they're extremely, extremely, extremely critically ill. When you're in pain, your heart rate goes up, your blood pressure goes up, right? The same thing is true for a patient who maybe has 20, of propofol on board and, rock, and the rock is still on and the propofol is not enough because they're a young, otherwise healthy person and they're a big guy. And you're hey, 20 mics per kilo per minute propofol is not a lot of sedation. So, if their heart rate and blood pressure are starting to creep up, 10, 15 minutes after you've placed the breathing tube, odds are they need more pain control. Odds are they need more sedation. And that's where we get a little bit more into if the patient's going to be paralyzed and asleep for a long time. If you have a Bis monitor, please use it. It's going to help you titrate your sedation better so that we're not over sedating patients either unnecessarily. but at least, that 40 to 60 range on the BIS, that number range, correlates with general anesthesia. Your patients probably don't need to be that deep in the ICU, probably 50 to 70 is probably a nice range to keep them in. If they're just going to be prone and paralyzed just to have ventilator compliance, they're not having a surgery performed on them necessarily. As long as their heart rate and their blood pressure kind of correlates with that as well, right? We don't just go off one number, we look at an entire clinical picture. Has that been your experience more or less, Anna? Have ICUs given you strict parameters? I know I did not have a BIS monitor as an ICU nurse at all.
Yeah, maybe 2 patients ever. They put the BIS on. I really didn't use it very much as an ICU nurse. I think more it's just good to be aware that that is a form of monitoring that can show how asleep a patient is. But I wouldn't worry too much if you don't see the BIS monitor all the time in the ICU. I know I didn't as an ICU nurse.
I would say it's also important to keep in mind, if they're paralyzed versus not paralyzed, because I think the way that we've learned to titrate sedation as nurses in the ICU is with behavioral pain scales to, you document that every time you do an assessment, right? What's the patient's pain based on the behavioral pain scale, and what's their RAS, the Richmond agitation, and what is it? Analgesia? Richmond?
Something like that.
RAAS, Richmond agitation and sedation scale, RASS, Richmond agitation and sedation scale. And based on if the patient's compliant with the ventilator or, whatever, that says if they have enough sedation on board or not. And it's a very loose guide. Well, that's all nice and fine and dandy, but the patient's not going to exhibit any of those signs if they're paralyzed, right? We've stopped them from being able to move. So keep in mind that your RAS scales and your BPS scales no longer apply to a paralyzed patient. You have to think about the clinical picture. Is this a young, robust patient who might need a lot of pain control and sedation, and now their heart rate and blood pressure going up? Give them pain control and sedation, right? Use your critical thinking skills. I would say never turn off sedation on a paralyzed patient, ever. Don't just turn it off. That's a terrible idea. I think the way that I was taught as a nurse, and correct me if I'm wrong, Anna, because it's been a long time. I don't know if this is what you guys are still seeing, but the level of sedation that patients, a lot of times when patients are being sedated, paralyzed in the ICU, they're intubated and sedated for a while on the ventilator, right? And then they're kind of spiraling the drain, and then we're having problems oxygenating them, and then we prone them, and then it's still not enough. And then we add on, a cisatracurium infusion, right? To help decrease that oxygen consumption and help them be compliant with the ventilator. So I was always taught whatever level of sedation they were at before we put on the paralysis to just keep it there. That's how you knew that they were asleep enough, just keep it there.
I would agree. They say don't go below what the patient needed before adding on paralysis, for sure. And then potentially also, if the patient then gets tachycardic, then add in more pain and more sedation medication kind of from that point. Because there was also, some of these patients, they were on ECMO, and who knows how much was getting sequestered, and sequestered meaning absorbent of the medication in the plastic tubing of the circuit, all that stuff. Always treat the patient was what I was told, was treat the patient. And if it looks like there's a question that they might be in pain, definitely treat the pain there. Which is why I think it's important for ICU nurses to know this stuff, right? Because you are the ones who are advocating for, you're seeing your patient for 12 hours a day. And if you know a little bit more about how long these medications work, then you can advocate to, get their pain treated appropriately.
I'm going to just encourage you guys one more time to please check out the pain versus sedation episode, because this ties into it so well. If your patient's heart rate and blood pressure are creeping up and you think they might need more, give pain control first. Pain control before sedation, and sedation before paralysis. That should be the order. You should first start with pain control. That goes into also train of 4. I think this was a common misconception that I hear a lot also. When you have a patient who's on a paralysis infusion, we do something called train of 4 monitoring. And again, we have that train of 4 lecture in the membership, and we can pop up an example of the electrodes here. But typically you got like 2 little electrode stickers, either over the ulnar nerve, you could do it over the facial nerve, you can actually do it over a lot of different nerves in the body, but typically ulnar nerve is where we recommend it. And you have this little box it hooks up to. It's got these electrodes. One is a black electrode, one's a red electrode, one's for grounding, one actually gives the electrical impulse. And once we stimulate with an electrical current over that nerve, it's going to cause muscle contraction. And when you hit the little train of 4 button, it's going to give a series of 4 electrical impulses. 1, 2, 3, 4. And you should see the thumb move. The adductor pollicis muscle is going to move with that electrical impulse, right? And so you will be asked as an ICU nurse to titrate your level of paralysis to usually like 2 twitches, like 1 to 2 twitches, because that means that enough paralysis is on board where we're blunting that ability to move around. We're reducing that oxygen consumption. We're encouraging compliance with the ventilator, but we're not over paralyzing them either, because long-term paralysis with these medications, even though they eventually go away and they can be reversible, it leads to faster muscle deterioration and muscle degeneration of your patients. And that's why it's important also to do those passive range of motion exercises with your patients that PT is always begging you to do. There's a reason for it. You're going to help your patient recover quicker in the long run with these passive range of motion exercises and active range of motion exercises. So literally like moving their body for them when they're paralyzed is actually really important. But this level of paralysis has nothing to do with how awake or asleep your patient is. So don't think like, oh, there's 0 out of 4 twitches and they look comfy. It means they're asleep. I can't tell you how many times I've heard that, and it makes me want to cry every time. But, and the same goes for the Bis monitor too, right? Like, oh, well, their Bis is 20, like they're paralyzed enough. Like, no. That's sleepiness, right? Like these are 2 totally different systems. So that's like an important point, I think, to kind of take note of if you're a nurse and you don't see this all the time.
Yeah, 100%. And I will have the link in the description for you guys to go join the membership where you're going to see that train of 4 monitoring lecture. That was also given by Kate. It's a whole 20-minute lecture. Can't recommend it enough if you're ever going to be taking care of patients who are on paralysis strips, because again, we can't really do all of that in a podcast episode. Go check that out. And then if you want a free lecture, check out the link in the description for the free epinephrine lecture. That is a sample of what you would get in the membership. Definitely everybody go check that out. And then completely agree with Chrissy. Sedation, pain control, not the same thing. Train of 4 monitoring monitors what percentage of those receptor sites are blocked by the paralytic medication. And then the Bis is sleepiness. So different things, very important. Always make sure that your patient is getting pain control, sedation. Watch all of the lectures, basically. And then what else do we have for people today, Chrissy? What else do we want to impart?
So I know I'm like torturing you guys here, but we have to talk about reversal. If we're talking about paralysis, we're talking about sedation, we're talking about Bis monitor, we have to talk about reversal, because this is also so not understood. And it's funny, like historically in anesthesia, I feel like we used to never reverse our patients before going up to the ICU. Like we brought up everyone with like a little bit of residual paralysis on board, because they'd have like a little bit of anesthesia gas left on board, or maybe like we ride them up with a propofol drip, and then like, then the nurses do what they want to do. And like by the time that like the patient's ready to extubate, 6 hours later, like of course the paralysis is worn off. Well, things have changed since the olden days. Patients don't stay intubated overnight 100% of the time anymore. Patients don't stay intubated for 6 hours anymore. Sometimes they roll up to the ICU and the breathing tube gets pulled right away. That's like, the new thing. We want to get patients extubated as soon as possible, because we've learned that long-term mechanical ventilation is bad for these people. So this is, another really important point. So, a lot of times I go to the units and nurses ask me, did I reverse the patient or not? But what if I say no? Sometimes like we might make a choice not to, right? Like, what does that mean for you? Like, what is the reversal drug? Does your ICU give it? Some do, some don't. If you do have to give it, like how does it work? How to do it safely? It's really important to know as an ICU nurse, if you bring up a patient who is not, if one of us, if a CRNA or anesthesiologist brings a patient to you who has not been reversed, even if you hook up the train of 4 monitor and get 4 out of 4 twitches, meaning all movement back, the patient could still be mostly paralyzed. And that's where your other assessments for extubation really come into play. And that's why there's actually studies coming out about how we should still be reversing our patients anyway. And Anna actually had a really great study pulled up. So Anna, do you want to talk about that a little bit more?
Yeah, totally. So this is something I was not taught when I was an ICU nurse. I only learned this in anesthesia school, that if a patient has 4 out of 4 twitches, meaning they get 4 out of 4 twitches when you do that train of 4, they can still be 70% paralyzed. That's a lot percent. That's a lot. That's a lot percent paralyzed, huh?
Paralyzed. Yeah, that's like more paralyzed than not paralyzed.
You know, The Princess Bride, like that's the quote that's coming to my mind right now. Yeah, 70% paralyzed is like very paralyzed. Okay, well, what does that mean? Oh, well, that's immediately, as an ICU nurse, you're thinking airway. Are there airway muscles? Are they 70% paralyzed? And the answer can be yes. I found this study. I will pull this up on screen if you're watching on YouTube. So a 2012 study found that 50% of patients who received reversal had residual paralysis on board. So they had 150 patients who got neuromuscular blocking agents, and they had a train of 4 monitoring in place near the eye muscles, and they had greater incidence of residual paralysis than patients who were monitored at the ulnar nerve, which is that adductor pollicis muscle. Residual paralysis was observed in 51 out of 99 patients, and 11 out of 51 patients. So that's showing that you should be doing the train of 4 monitoring on the ulnar nerve over the facial nerve, and that about half of patients who had that train of 4 monitoring done on the face had residual paralysis on board after reversal was done. So this is something, again, I didn't know.
Wait,
this would have been news.
After reversal was done too? I didn't even notice that. That's... Oh, damn. Okay.
Yeah, so they're showing bad. we really shouldn't be doing the facial nerve monitoring. We should be doing the ulnar nerve monitoring and giving reversal. Damn. Which is wild, right?
Damn. Well, I'll tell you guys a little clinical pearl about this really quick. And I don't want to derail it, but I think a lot of times when people monitor the facial nerve, they're accidentally putting the electrodes right over the orbicularis oculi muscle, which is like right above the eyebrow, instead of putting it along the facial nerve itself. And the problem with that is when you directly stimulate the muscle, like you're going to over paralyze the patient, because whenever you directly stimulate the muscle, like you essentially you cause so much acetylcholine to be released at the neuromuscular junction that it kind of like binds to all the little receptors that like the rocuronium, for example, has not bound yet. And like you'll cause muscle contraction quicker than if you stimulate it further back at this, like along the line of the nerve. So you'll kind of falsely see return of twitches before they really would be back, as if you were just on the facial nerve. So that's one factor that goes into it, like monitoring it. And I don't know about in this study particularly, but like in general, if you are going to monitor along the facial nerve because of like, maybe you can't reach the patient's hand during surgery, right? Like if the arms are tucked, like what are you going to do? Like you got to do what you got to do, right? Like the facial nerve is where it's at. Make sure you're staying along the facial nerve, not on the orbicularis oculi. But also, yes, the adductor pollicis is a better reflection of what's going on in the body, namely the diaphragm. And I'm going to let you get back to that point, than the facial nerve. But anyway, little tip. Keep going.
It's all so interesting. I think we're all just trying to get all of y'all to go to anesthesia school, because there's so much here and it's fun. Like we could talk forever. I think it is helpful for ICU nurses to also know kind of the order of operations, PIMDOS, if you will, like what muscles get paralyzed first and what gets paralyzed last, because that matters, right? If you're extubating a patient. So, or intubating a patient, right? So it's important to know that the order of operations is that your eyelid muscles are paralyzed first, and then your extremities, then your trunk, abdominals, and then diaphragm. So that's I like to think kind of outside in and then inside out. So then for reversal, your diaphragm regains motor muscle like function first, then your abdominals, then your trunk, then your extremities and your eyelids. And then of note, the muscles in your upper airway and inside of your throat, they behave as like central muscles for the onset of paralysis, but they're slow to recover and they mirror the more peripheral muscles. So what does all of that mean? So once you give your patient a reversal, it's important to know that if they are able to swallow and pick their head up, they're closer to being ready to get that breathing tube out, because your airway muscles, which you'll learn in anesthesia school, are kind of slow to recover from those neuromuscular blocking agents. Do you have anything to add, Chrissy?
No, I mean, that's perfect. And that's again why like it's important that we're monitoring the peripheral muscle. The adductor pollicis is going to reflect better like the airway muscles, right? Because those are like sort of the last things to recover. That's also for like the SRNAs out there, people who are already in the OR. Like sometimes your surgeon will be like, is your patient paralyzed? And you're like, they have 0 out of 4 twitches. Like, what are you talking about? Like, well, they can see the diaphragmatic movement before you can because they're in the abdomen. And like, you'll start to see like sometimes like motion on the ventilator, like curare clefts, like the patient starting to try to breathe over the ventilator because the diaphragm does come back before the, your train of 4 will on the hand. But in addition to that, what should we be looking as extubation criteria for everyone out there? This is a great quiz question in the operating room. They talk about 5-second head lift being like one of the keys to knowing if your patient's ready to extubate. If they could lift their head and hold off the bed for 5 seconds, it's a really good sign your patient's really strong. There is like a study out about how one of the best measures is like, can they bite on a tongue blade? But I don't really think I've ever seen that, because you have to like, I feel like patients have to be pretty awakened with it to like chomp down and bite on something. But either way, the point is they should have a 5-second head lift. They need to be taking good volumes on the ventilator on their own. They should be able to squeeze your hands, have good hand strength. That's another one. So we're looking for clinical signs of recovery, and the patients should get reversal. And there are circumstances in which you might have to give reversal. One time I gave reversal as an ICU nurse. This was in the pre-Sugammadex days. We had a patient with myasthenia gravis, and she was ready for extubation after her cardiac surgery. And it hadn't been that many hours after surgery. And so the anesthesiologist said, let's give her reversal. And he ordered the reversal. And then I never heard of these drugs before. It was neostigmine and glycopyrrolate. You're supposed to give them together. And I asked everyone on the unit about it. I asked pharmacy about it. I tried looking it up. I asked the charge nurse about it. I asked the MP about it. I asked every single person, is there anything I need to know before I give this drug? Is there anything I need to know before I give this drug? Is there anything I need to know before I give this drug? And I gave the drugs. And then I came back and the anesthesiologist said, did you give the drugs? I said, yes. He's like, what order did you give them? I said, what do you mean? He's like, which one did you give first? And I was like, I gave them back to back, but I gave the neostigmine first, and then I gave the glycopyrrolate. And then he screamed at me. Because that's a bad thing. You were supposed to give the glycopyrrolate first because neostigmine can cause bradycardia.
But nobody told you that. It's hard.
Nobody told me that. I had 6 people. I tried so hard. But we're telling you that, so you don't have that issue. If you work in a nice academic medical center, you'll probably use Sugammadex, and the risks of side effects are pretty low, although not zero. There is a small incidence of bronchospasm after Sugammadex, so you wait a minute or two before you extubate your patient. But other than that, it's a pretty safe medication. So far, so good, even though it's new-ish to market. But if you do give neostigmine and glycopyrrolate, make sure you give the glycopyrrolate first. And quick side note, neostigmine stops the breakdown of acetylcholine by the enzyme acetylcholinesterase at the neuromuscular junction. So what does that mean? It allows acetylcholine to build up and then outcompete the drugs, rocuronium, whatever it may be, and then kind of like bump it off the site and like do its thing. It allows it to work, right? Which is great. But as we have that like buildup of acetylcholine throughout the rest of the body, too much acetylcholine binds all of its other receptors too, right? Like the muscarinic receptors at the heart, for example, and that can cause bradycardia. So we want to prevent the bradycardia with an anticholinergic agent like glycopyrrolate, for example, we give that first, and that prevents the bradycardic effects of the neostigmine and also some of its other negative side effects, right? Like there's all these horrible side effects that neostigmine has if you don't give it alongside glycopyrrolate besides bradycardia, but you want to give the glyco first before the neostigmine is the take-home point.
Yes. And I think I will just add and say in even simpler English that neostigmine essentially is given to stop the action of the paralytic. And it has kind of an interesting mechanism of action, but you give neostigmine to stop the paralysis agent, and you give it with glycopyrrolate to kind of mitigate the side effects of that medication. And then sugammadex binds directly to the paralyzing agent itself, and it's super nice and fancy, but it costs a lot of money. So if you happen to be a nurse who's giving these medications on the unit, I would run it by your provider first, and then always give the glycopyrrolate or the atropine before you give the neostigmine. Also, one other kind of takeaway is that you want to make sure that your patient's normothermic before you reverse them. And by normothermia, usually greater than 36 degrees Celsius. You want to make sure that they're not cold because you can have some negative side effects there. If we don't watch out, Chrissy and I, we're teachers at heart, and this episode could be very easily like a 2-hour lecture. I think that's what we wanted it to be, but the lectures are in the membership. So check out the membership. But back over to Chrissy. What else do you have for reversals?
No, I think that's the main take home point. Ask if the patient's been reversed or not. Know that if they have not been reversed, then there could still be paralysis on board, and you have to have a really good clinical assessment of if your patient's ready. They should not be taking rapid, shallow breaths. They should be nice, full, tidal volumes. They should be awake. They should be strong. They should be able to lift their head off the pillow. If they have been reversed, I guess it's still theoretically possible for it to be inaccurate reversal. I should say this. Back in the days of neostigmine glycopyrrolate, people had residual agent on board all the time. All the time. People would reverse before we really had enough twitches back. And the qualitative assessment with train of 4 monitoring is not a super accurate way to assess how paralyzed a patient is. Once again, like we just talked about that, there are better ways. There's quantitative assessments, which is a whole nother device. It looks at train of 4 ratio. It's a whole nother lecture. But the point being that if you're in a hospital and they're not using sugammadex, there could be inadequate reversal. If your patient looks kind of weak and shallow breathing after extubation, they might need to be reintubated, or they might need to, you might need to advocate that someone comes and looks at them. So we want to be closely monitoring our patients after extubation. Again, clinically assessing them, not just looking at numbers on a monitor. Don't just look at the O2 sat. Look at their chest rise. Look at how they sound. Are they gargling? Are they talking? They should be able to speak to you after they're extubated. They should not look like they're in distress in any way. So these are all of your important take-home points about reversal.
And if this is exciting, check out all of the lectures and join us in anesthesia school because it's fun. It's very interesting. All of the different mechanisms and pathways that everything works. It's there's learning, and then there's learning that's kind of fun. And this is learning that it's interesting because it's very directly related to our patients, right? So it's a little dense, but it's very interesting. And if you feel that way, you enjoy the learning process, you're definitely in the right place. Make sure that you check out the link in the description for the free epinephrine lecture for all the Confident Care Academy members. Definitely check out the Train of 4 monitoring lecture in the membership. Links to both of those will be in the description below. Please comment what you want us to talk about next time, and please subscribe. Thanks for the support.